So, picture this. A 62-year-old widow sits in a psychiatric clinic.
Okay.
Her husband passed away recently, right? And she looks across the desk at this young, really empathetic psychiatric resident, and she says, I just feel completely empty inside.
Oh, yeah. I know exactly where this is going.
Right. So the resident nods. They offer this warm, comforting smile because, they're assuming she's talking about the profound, aching loneliness of grief.
Which is a completely natural assumption to make.
Exactly. So they make this gentle psychological interpretation about the nature of loss. It's a very human moment. But the resident is completely disastrously wrong.
Spot on. Because the patient does not mean she is metaphorically lonely.
No. She means she is literally empty inside. She genuinely believes her internal organs have been removed.
It's perhaps one of the most sobering cautionary tales in all of clinical psychiatry.
It really is.
Because the resident heard a deeply profound, concrete delusion. I mean, a manifestation of severe psychosis, and they just completely missed it. And they missed it because they assumed the patient's mind was working exactly like their own. They took this terrifying biological and psychological reality and just painted over it with her own narrative.
And that perfectly sets the stage for our mission today. So, welcome to the deep dive. We are thrilled you're joining us because today we are fundamentally unpacking how we even begin to understand the human mind when it's in distress.
We are taking the foundational principles of the psychiatric interview and the mental status examination, the MSE, and we're really digging in.
We're using the absolute gold standard frameworks from clinical psychiatry, primarily drawing from Kaplan and Sadek's comprehensive textbook of psychiatry, right?
Yes, exactly. And we're merging those clinical frameworks with the much deeper philosophical questions of, well, what a mind actually is.
Right. Because before we can treat a mind, we have to ask what a mind is. I mean, are we just a biological machine?
Or are we a collection of subjective experiences?
Or a relational process? We are anchoring everything today around one core tenet, and it's this. Psychiatry is the study of how the brain, the mind, and human experience interact. And critically, how that beautiful, complex process can go wrong.
That is the perfect framing.
Yeah.
And, to truly understand that interaction, we have to look at the primary tool we have to measure it.
Right.
If you think about the history of medicine, there has always been this drive toward reductionism.
Yeah, reducing things down.
Exactly. The idea that we can reduce complex human suffering down to a single biological metric, like a malfunctioning valve in the heart.
Or a spike in white blood cells.
Right. Or a fracture on an X-ray. In those fields, the physician has a scalpel, or they have a high-resolution MRI, or a genomic sequencer to find the objective truth.
But psychiatry isn't like that. It sits right at the intersection of science, psychology, and philosophy.
We cannot simply biopsy a delusion.
Yeah.
We can't draw blood to measure the exact volume of someone's despair.
Right. There is no blood test for the loss of free will that comes with severe addiction or the fracturing of the self that happens in schizophrenia. The ultimate instrument, the most powerful, sensitive, and versatile tool the psychiatrist actually possesses is the conversation itself.
Yes. It is the clinical interview.
Right.
The pioneering physician George Engel made this point decades ago. He established that the clinical interview is virtually indispensable. But it's not just a chat.
No, definitely not.
It is a highly calibrated, dynamic procedure. You are stepping into the patient's reality, trying to map their internal world, while simultaneously keeping one foot firmly planted in objective clinical science.
It's a phenomenological exploration.
Exactly. We are not just cataloging symptoms. We're trying to understand the patient's lived experience of those symptoms and how their philosophical assumptions about their own existence have been altered by illness.
I always picture it like a detective investigating a mystery, but the mystery is taking place inside a labyrinth.
Ooh, I like that.
And the walls of this labyrinth aren't made of stone. They are made of memory, trauma, defense mechanisms, and shifting emotional states.
Right.
As you walk through it with the patient, the walls constantly move. Like if you push too hard, a wall drops down to block you.
Yes, it was shut down.
But if you sit quietly, a new corridor might open up. So the goal of this deep dive for you listening today is to explore exactly how to navigate that labyrinth.
We are going to examine how to move from the deep, often unconscious mechanisms of human communication to the physical manifestations of mental illness.
And finally, to how all of that translates into rigorous clinical reasoning. So to begin navigating that labyrinth, we have to establish the core conceptual framework.
Right. And the very foundation of the initial psychiatric encounter is built upon two primary simultaneous aims.
Okay.
And this is where that tension between reductionism and holism immediately presents itself. The first aim is developing a comprehensive biopsychosocial database.
Which is the reductionist scientific side of the endeavor.
Exactly. You are gathering the raw data necessary to formulate an accurate diagnosis, assess imminent risk, and structure a treatment plan based on established medical criteria.
So that's the detective looking for the exact dimensions of the footprint, checking the boxes.
Yeah.
Sleep, appetite, family history of thyroid disorders, prior medication trials. It's highly analytical.
Yes, very analytical. But the second aim is entirely holistic. It's forming a positive therapeutic alliance.
Ah, right.
You must establish a profound human connection, a sense of safety and trust, because without that alliance, the database is utterly useless.
Because the patient just won't come back.
They won't return, or they just won't reveal the most critical pieces of the puzzle. So these two aims, the objective data gathering and the subjective relationship building, they can frequently compete with one another.
I think this is where anyone outside the field, or really anyone who has ever sat in a doctor's office, feels that friction.
Oh, absolutely.
I mean, how do you balance being a rigorous, objective data gatherer who is secretly trying to check off DSM-5 diagnostic criteria in your head with being a comforting, empathetic human being who is fully present for someone suffering?
Just tough.
It feels like those require two completely different neurological states. One is the cold, calculating prefrontal cortex, and the other is the warm, resonant limbic system.
It is the ultimate clinical balancing act, and it requires immense cognitive flexibility.
So how do you actually manage it?
Well, the way you begin to manage that tension is by manipulating the environment itself. The physical and psychological stage dictates the performance.
Right, because these encounters do not just happen in quiet, mahogany-lined private practices.
Not at all. They happen in chaotic emergency departments, on busy medical surgical wards, and acute inpatient units, and in the concrete blocks of correctional facilities.
And increasingly through the digital barrier of telepsychiatry.
Yes, telepsychiatry too. But regardless of the setting, the clinician has to aggressively optimize comfort, safety, and privacy. You cannot build a therapeutic alliance if the patient feels physically or psychologically exposed.
Let's drill down into the safety aspect because the clinical realities of this are fascinating.
Okay.
Let's say you are working in an emergency department and a patient comes in acutely agitated.
Right.
They might be experiencing a manic episode or severe psychosis or intoxication. The mechanism of their distress is manifesting as loud, unpredictable, perhaps even threatening behavior.
Yes.
If we look at the clinical response, the traditional literature suggests something called a therapeutic show of force. Now, to an outsider, that sounds quite aggressive. It sounds like a prison guard tactic.
It does sound intimidating, I admit.
Yeah.
But the clinical meaning and the psychological mechanism behind it are actually the exact opposite of intimidation.
How?
When a patient is acutely agitated, they are often terrified by their own loss of internal control. Their brain's executive functioning has gone offline, and their threat detection circuitry is just in overdrive.
They feel as though they're flying apart.
Exactly. So a therapeutic show of force involves gathering an adequate, visible presence of calm, professional staff.
Ah.
The unspoken message is not, we are going to hurt you. The message is, your internal world is out of control right now, but our external world is highly controlled.
We are strong enough to keep you safe.
Yes. To keep you safe, to keep the staff safe, and to prevent you from doing something you will regret. It provides an external container for their internal chaos.
That makes total sense. It is essentially outsourcing their executive function for a moment. You're providing the brakes because their brakes have failed.
Exactly.
And there is another technique that I found profoundly striking, especially for clinicians who are alone in a room with a difficult or escalating patient.
Oh, naming the emotion.
Yes. The literature suggests explicitly naming your own emotional state to the patient, literally saying something to the effect of, when you swear at me and speak in such a loud voice, it makes me very anxious. And when I am anxious, it interferes with my ability to listen to you and help you.
It is a radically genuine intervention. And it relies on a specific philosophical view of the clinical relationship.
Right.
It's the view that it is a mutual relational process between two human beings, not a unidirectional transaction from a pristine expert to a broken subject.
Yeah.
By admitting your own anxiety, you completely alter the power dynamic. You step down from the pedestal of the unflappable doctor and invite the patient to recognize their impact on another human being.
Which, for many patients, particularly those who use intimidation as a maladaptive defense mechanism, this honesty is deeply disarming. It re-engages their own capacity for empathy.
It does.
It reminds me of that famous adage, often attributed to Maya Angelou. People will forget what you said, people will forget what you did, but people will never forget how you made them feel.
That is so true. The patient's very first emotional encounter dictates their entire trajectory of care. If they leave that first session feeling unheard, judged, or emotionally unsafe, they are not coming back.
And the meticulous clinical database you built is entirely meaningless?
Exactly. And that leads us to consider what happens before the conversation even begins, the pre-interview phase.
Right, the screening tools.
Yeah. Modern practice heavily incorporates screening tools. Patients might complete a PHQ-9 for depressive symptoms, or a QLESQ questionnaire surveying their quality of life in the waiting room or via a digital portal.
Which are rooted in the reductionist model, right? They attempt to quantify subjective distress into numerical scores, which sounds incredibly efficient. I mean, if I have a tool that asks a patient to rate their sleep, their mood, and their energy on a scale of 0 to 3, why not just use the app to make the diagnosis and save the 50-minute hour?
Well, because an app cannot discern context, meaning, or motivation. These tools are hypothesis generators, not definitive diagnosticians.
Right.
They are excellent at identifying clusters of symptoms, but they are entirely vulnerable to false positives and false negatives.
Like what?
Well, a patient might score very high on a depression scale, not because they have a primary depressive illness, but because they are grieving a catastrophic life event.
Yeah.
Or because they have an undiagnosed thyroid condition. You cannot outsource the interpretation of a human life to a piece of paper. The clinician must contextualize the data.
That's a great point. And there is also the reality of third parties in that pre-interview phase, the family members who drag the patient into the clinic, or the spouse who calls ahead to warn the doctor about what is really going on.
Oh yes, the collateral information.
There's a magnificent foundational principle here. No meeting about me without me.
It is a cornerstone of trust. If a patient walks into your office and suspects you have already conspired with their spouse or their parents behind their back, the alliance is dead on arrival.
Yeah, I'd be furious.
Right. So the standard sequence is to meet privately with the patient first. You establish that they are your primary responsibility. Then, with their explicit consent, you can initiate the family members into the room.
Ensuring the patient is present to hear exactly what is being said about them.
Exactly. Furthermore, the clinician must explicitly define the boundaries of HIPAA and confidentiality immediately.
You have to outline the exceptions, right? Imminent risk of suicide, imminent risk of violence to others, or the suspected abuse of a child or vulnerable adult.
Yes, and stating these rules up front does not inhibit the patient. It actually creates safety. They know precisely where the walls of the container are.
Which transitions us beautifully into the mechanisms and models of the interview itself. Let's look at the dance of engagement and how different philosophical frameworks change the very questions we ask.
Okay.
We can contrast the traditional deficit-focused medical model with a more holistic, person-centered approach.
Right. The traditional medical model is fundamentally pathology hunting. It asks, what is broken and how do we fix it?
Which is necessary, of course, for identifying disease states.
It is. But a strictly deficit-focused approach can be incredibly demoralizing for a patient who already feels defined by their illness.
Yeah.
A person-centered approach, drawing heavily from humanistic psychology, assumes that the individual has inherent strengths and a drive towards growth. A clinician using this model might ask, tell me about some of the things you do best, or what has helped you survive this long?
I love that. It completely rewires the energy in the room. You aren't just a collection of broken gears. You are a person with resilience who happens to be struggling.
Exactly. Historically, this reflects a long-standing debate in psychiatry. Early in the 20th century, figures like Adolf Meyer championed life charts, trying to map the entire psychobiological history of a person.
Their culture, their childhood environment, their unique stressors.
Yes, it was deeply holistic. But as the field evolved, it required more standardization, leading to the criteria-based approach of the modern DSM-5. The master clinician does not choose one over the other. They weave between them.
They hold the holistic, subjective reality of the unique human being in one hand and the rigorous, reductionist criteria of the diagnostic manual in the other.
Precisely.
And as you are weaving between those two, you have to employ empathy. But I want to pause here because this is a concept that is so universally misunderstood.
Oh, it really is.
In casual conversation, you and I might use the words empathy and sympathy interchangeably, but in clinical practice, mixing them up is not just a semantic error. It is actively dangerous.
It is a vital distinction, and it goes right to the heart of how the clinician manages their own mind. Empathy is the capacity to appreciate and understand the patient's internal experience at an emotional level.
Right.
You achieve this by actively imagining yourself in their position, feeling the resonance of their distress, while, and this is the absolute crux of it, simultaneously maintaining your own objectivity.
You never forget that the emotion belongs to the patient, not to you.
Exactly. Sympathy, conversely, is identifying with the patient. It is losing the boundary. You fuse with their pain, and in doing so, you lose your objectivity.
I always think of it like finding someone drowning in quicksand.
Okay, I like this.
If you feel sympathy, you jump into the quicksand with them to show them how much you care that they are suffering. But now there are just two people dying in the quicksand, and neither of you can get out.
Right.
Empathy is standing firmly on the solid bank, acknowledging how terrifying it must be to sink, but keeping your feet planted so you can actually throw them a rope.
That is a phenomenal analogy, and the clinical literature provides a stark warning about this, particularly regarding patients with severe personality disorders.
Like borderline personality disorder?
Yes. Consider a patient with borderline personality organization whose internal world is characterized by chronic emptiness, intense fears of abandonment, and emotional dysregulation.
Yeah.
The author Sean Shea cautions against the clinician who boldly proclaims, "I can feel your pain," or who feels compelled to become the ultimate savior for this poor, suffering soul.
Right, because if you fuse with their pain, you are reinforcing their lack of boundaries. They don't need you to be enmeshed with them. They need you to be a stable, predictable, grounded anchor.
Exactly.
But that leads to a much darker question. Empathy is relatively easy when the patient is suffering and seeking help. What happens when the patient is, well, deeply unpleasant?
Yes.
There is a classic, somewhat infamous 1978 paper by James Groves titled Taking Care of the Hateful Patient. Just hearing that title feels taboo in modern medicine.
It is jarring, definitely, but it addressed a profound reality that the medical establishment often tried to ignore.
What did he find?
Groves categorized specific patterns of patient behavior, those who were endlessly demanding, chronically manipulative, or aggressively rejecting of help that genuinely evoke feelings of dread, anger, or even malice in the physician.
Wow.
The philosophical imperative here is honesty. If a clinician cannot recognize and admit to their own disdain, that unconscious anger will inevitably manifest in their behavior.
Like they'll act out against the patient.
Yes. They will subtly punish the patient, perhaps by making them wait longer, discharging them prematurely, or ordering unnecessary painful tests.
It is the shadow side of the clinical encounter. You have to admit you are human and that you are capable of disliking the person sitting across from you.
You do.
As Francis Peabody wrote almost a century ago, the secret of care of the patient is caring for the patient. But as we know, caring is not an automatic physiological reflex. It is a conscious, sometimes extremely difficult choice.
Which brings us squarely into the realm of the unconscious. When two people sit in a room, they're not just exchanging semantic data, they are communicating through an invisible, dense network of unconscious assumptions, historical traumas, and defense mechanisms.
Yes, the concept of transference. I like to conceptualize transference as a form of emotional muscle memory.
Okay, tell me more.
Imagine your nervous system spent 20 years learning to flinch because you had a deeply critical, unpredictable parent. Your brain wired itself to survive that specific environment.
Right.
Then you walk into a psychiatrist's office. You've never met this doctor before, but they happen to use a certain tone of voice, or they have a specific posture, or they simply represent an authority figure.
And trigger that memory.
Exactly. Before you are even consciously aware of it, your emotional muscle memory fires. Your brain slaps a filter over your perception, and suddenly, this objective clinician looks exactly like the critical parent. You begin reacting to the ghost of your past rather than the reality of the present.
That is an exceptionally precise way to describe the mechanism. Transference is the unconscious displacement of feelings, attitudes, and behavioral expectations from significant figures in the patient's past onto the clinician.
And it is ubiquitous.
Yes, it is not just a psychoanalytic concept. It is a fundamental feature of human neurobiology pattern recognition applied to social relationships. And crucially, it is bidirectional.
Countertransference.
Exactly. Countertransference is the exact same process occurring in the physician, displacing their own unresolved historical material onto the patient. If the clinician is not rigorously monitoring their own internal state, these unconscious distortions will drive the entire clinical encounter into a ditch.
And as the patient is navigating this emotional minefield, their ego is constantly trying to protect itself from anxiety. This is where defense mechanisms emerge.
Right.
It's not just crying or shutting down. It is often hidden in the linguistics. The clinical teachings point out things like slips of the tongue, chronic lateness, or my absolute favorite, phrases like, to be honest with you, or to speak frankly.
It is a fascinating linguistic tell. When someone preemptively announces that they are about to be honest, it often unconsciously signals that what follows, or perhaps what preceded it, is heavily filtered, guarded, or entirely deceptive.
Oh, definitely.
But identifying a defense mechanism is only the first step. The more important clinical question is what you do with it. The overwhelming consensus for an initial interview is restraint. You observe the defense, you make a mental note of it, but you do not immediately interpret it or tear it down.
Because it's there for a reason.
Yes, the defense mechanism is a load-bearing wall protecting a fragile ego. If you shatter it before you have built a secure therapeutic alliance, you will flood the patient with anxiety, and they will likely terminate treatment.
You have to earn the right to challenge the defense.
Okay.
You can't just walk into someone's house and start rearranging the furniture.
Precisely.
To really solidify this idea of navigating the relational space and the unconscious, the literature provides an incredibly illuminating clinical vignette. Let's walk through it.
Okay, let's do it.
A psychiatrist is seeing a newly admitted patient, let's call him Mr. Smith, who is suffering from major depressive disorder. The doctor walks in, introduces himself, and before he can even ask the first diagnostic question, the patient interrupts and aggressively demands, "Are you Catholic?"
And the patient draws a hard line in the sand. He states categorically that he will not answer a single question until the doctor answers his.
Right, so the novice instinct might be to just answer the question to get it over with, or to rigidly refuse and quote hospital policy. But the experienced clinician in the vignette tries to reflect it back. He says, "I can see that's very important to you. Can you tell me why?" But the patient stonewalls. He says, "I'm not going to say anything till you tell me."
And the doctor presses on again, trying to figure out the motive before answering.
Right. Why is it so crucial from a clinical reasoning perspective to understand the why before giving the what?
Because the question is almost never just a question. It is a manifestation of an underlying psychological state. By delaying the answer, the clinician is hypothesis testing.
Hypothesis testing.
Yeah, like, is this patient terrified of being judged because they suffer from scrupulosity, a form of religious OCD, and they fear a Catholic doctor will view them as a sinner?
Oh, that makes sense.
Or did they have a profoundly traumatic experience with a non-Catholic clinician in the past? Or are they experiencing a paranoid delusion involving the Vatican? If the doctor simply says, "Yes, I am," they entirely lose the opportunity to map the patient's internal world.
But in the vignette, the patient absolutely refuses to budge. They have reached a complete stalemate. If you answer that question, I'll answer whatever questions you have.
And this is where clinical dogmatism must give way to pragmatism. The doctor recognizes that continuing to withhold the answer is now actively harming the alliance. So he answers. He says, "Okay, I'm Catholic."
And immediately the patient fires back, "Do you go to Mass every week?"
It's a trap.
Yeah.
The boundaries are being tested again.
But the broader philosophical rule here is paramount. The literature explicitly dictates self-revelation must always serve the patient.
Always.
It must be a calculated intervention to strengthen the therapeutic alliance, never to serve the doctor's ego, their desire to be liked, or their own discomfort with silence.
Exactly. You must possess the rigidity to hold the frame and the flexibility to bend it when the patient's humanity demands it.
All right, let's transition from the relational dynamics into the actual architecture of the data gathering, to building the database or the psychiatric history.
This is the structural spine of the encounter.
And it begins with the history of present illness, the HPI. While we are gathering a chronological timeline of symptoms, the absolute core conceptual question the interviewer must answer is, why is the patient presenting now?
Yes, the phenomenology of time is critical here. Psychiatric illnesses, depression, anxiety, schizophrenia are frequently chronic or episodic. They brew over months or years. So why, on this specific Tuesday afternoon, is this person sitting in this chair?
The precipitating event provides immense context.
It does. A patient might say, I've been feeling low for a year, but I'm here today because my girlfriend told me last night that if I don't get help with this, she is leaving me. That one sentence tells you about the chronicity of the illness, the fragility of their social support network, and crucially, their locus of motivation. They are not entirely intrinsically motivated to change. They're externally coerced by the threat of abandonment. That drastically alters the treatment plan.
And as you gather this narrative, you are simultaneously conducting a review of systems. And this is where the mind-body bridge becomes so apparent. We are evaluating emotional distress, but we are asking about purely physical systems.
Let's look at the classic mnemonic used to screen for major depression, PSYCH gaps.
Yes, PSYCH gaps.
It maps the neurovegetative symptoms of depression, proving that psychiatric illness is not just a state of mind, but a systemic biological disruption.
So let's break it down.
S is for sleep changes, either severe insomnia or hypersomnia. S is for loss of interest or anhedonia. G is for excessive guilt. E is for low energy.
C is for reduced concentration, reflecting cognitive slowing.
A is for appetite changes, leading to significant weight loss or gain. P is for psychomotor changes, either profound retardation, where they move as if underwater, or psychomotor agitation, where they are pacing and wringing their hands.
And S is for suicidality.
Yes.
I want to pause on that because the fact that an emotional state like profound sadness physically alters your gut motility to change your appetite or rewires your circadian rhythm so you wake up at 3:00 a.m. every night. It shatters the philosophical illusion that the mind and the body are separate entities.
It really does. The brain is an organ, and depression is a systemic illness.
And that last suicidality brings us to the highest stakes portion of any evaluation. Risk assessment. The conceptual framework here is that risk is never static. It is a fluid, dynamic interaction of genetics, environmental stressors, and acute symptomatology.
Assessing that risk is the heaviest burden the clinician bears. And because patients frequently withhold suicidal intent due to intense shame or the very rational fear that they will be involuntarily confined, the clinician must be highly strategic.
The literature recommends specific interviewing methodologies, right?
Yes, most notably, the case approach, the chronologic assessment of suicidal events, developed by Sean Shea.
The genius of the case approach is its mechanism. It bypasses the patient's psychological defense of denial by moving away from abstract emotions and demanding concrete behavioral facts along a continuum of lethality.
It is chillingly precise. You don't just ask, are you suicidal, and check a box when they say no. You move systematically down the timeline. You ask about the ideation, then the plan, then the action.
The literature outlines this terrifying progression of questions. You ask, have you thought about how you would do it? If they mention a firearm, you ask, is there a gun in the home?
Right.
If yes, have you taken out the gun? Did you procure ammunition? Did you load the gun? Did you hold it? Where did you point it? How long did you point it? And critically, what stopped you?
You are meticulously stripping away the ambiguity. The goal is to determine the precise level of intent and the proximity to the act. Any developed plan or any behavioral practicing of a suicide attempt must be viewed as an acute, high-risk finding requiring immediate intervention.
And this level of rigorous, reductionist medical investigation must also be applied to the medical and family history.
Because at the end of the day, a psychiatrist is a medical doctor first. We cannot assume that every psychological symptom has a psychological origin.
The literature provides exceptional examples of why this medical vigilance is non-negotiable. Imagine a primary care physician diagnoses a patient with mild depression and starts them on a tricyclic antidepressant, a TCA.
Right.
A few weeks later, the patient develops severe shortness of breath. If the psychiatrist doesn't do a full systemic medical review, they might assume the patient is having panic attacks. But the reality is the medication is exacerbating an underlying congestive heart failure. The drug is literally poisoning the heart.
Or consider the classic masquerader. Hypothyroidism. A patient presents with profound lethargy, weight gain, depressed mood, and cognitive fog. It looks exactly like major depressive disorder.
But the etiology is entirely endocrine.
Exactly.
Yeah.
If you prescribe an antidepressant, you fail the patient. The required treatment is thyroid hormone replacement. Furthermore, the family history is a vital biological and psychological map.
We pay particular attention to a family history of completed suicides, right?
Yes. A history of completed suicide in a first-degree relative significantly elevates the statistical risk for the index patient, likely due to a complex interplay of genetic loading for impulsivity and the psychological modeling that suicide is a viable exit strategy from pain.
All right, we have constructed our historical database. Now we move into the actual observation of the present moment. The clinical manifestations, specifically the mental status examination, or MSE.
The MSE.
If the history is the story of the mind, the MSE is the physical examination of the mind. This is where we attempt the seemingly impossible task of taking subjective, chaotic human experience and categorizing it into objective, standardized clinical observations.
We had to break this down systematically, starting from the second the patient enters the room.
It begins with appearance, motor activity, and eye contact. We are observing the physical vessel, and eye contact is particularly profound from an evolutionary psychology perspective.
Oh, absolutely.
In primates, including humans, prolonged, unbroken eye contact is a mechanism that regulates either intense intimacy or dominance and threat. If you have a patient who is deeply depressed, they may stare at the floor, breaking contact entirely to signal submission and social withdrawal.
But if you have a patient who is actively psychotic and highly paranoid, they might fixate on you with an unblinking, intense stare. They are hypervigilant, monitoring you as a potential predator.
And the clinical guidance here is crucial. If you lock eyes with a profoundly paranoid patient, trying to show them you are listening, their amygdala, the threat detection center of the brain, interprets your empathy as a dominance display.
Yes.
It perceives you as a predator preparing to strike. You have to consciously avert your gaze to de-escalate their nervous system.
You are also observing their motor activity, using tools like the Abnormal Involuntary Movement Scale, the AIMS test.
Right, looking for those subtle movements.
Exactly, the lip-smacking or choreotheatoid movements that indicate tardive dyskinesia, a permanent neurological side effect of older antipsychotic medications.
Then we evaluate mood and affect, which requires a vital distinction. These terms are often confused, but they measure entirely different dimensions of emotion.
I know you have a great analogy for this.
I always find the weather analogy to be the cleanest way to explain this. Mood is the overall long-term climate. It is the internal, subjective state that the patient reports to you. You have to ask them, how are you feeling? And they might say, I feel desolate, or I feel fantastic.
But affect is the current observable weather outside the window right now. It is what the clinician objectively sees in the room, the microexpressions, the prosody of their voice, the posture.
Precisely. And we categorize affect using several parameters. We look at the range of emotion. Is it full and dynamic? Is it restricted?
Or is it blunted, where the emotional expression is significantly reduced? Or is it entirely flat, devoid of any emotional resonance, which is a classic negative symptom of schizophrenia?
We also look at lability, where emotions swing wildly and unpredictably from tears to laughter. And crucially, we assess congruence.
Do the climate and the weather match?
Right. If a patient states their mood is devastated, but their affect is characterized by a wide grin and inappropriate giggling while discussing the death of a loved one, the effect is profoundly incongruent.
And this incongruence often points towards a disorganization of the mind, such as in schizophrenia.
Okay, now we dive into the machinery of thought itself. We separate this into thought process, which is how the ideas connect, and thought content, which is what the ideas actually are.
Let's look at thought process, or thought form, first.
This is observing the train tracks. How does point A connect to point B in the semantic networks of the brain? The literature defines specific manifestations that are crucial to differentiate.
Let's delineate them. Circumstantial thought is when the patient's thought process is highly circuitous. You ask a simple question, and they provide an excruciating amount of unnecessary detail, taking several detours.
But they do eventually return to answer the target question.
Yes, the conceptual link remains intact.
So circumstantial gets to the destination, it just takes the scenic route. But tangential thought is different. I always struggle with how to differentiate tangential thought from just, someone who is a naturally scattered storyteller. How do you draw that clinical line?
The clinical line is the destination. In tangential thought, the patient takes an exit ramp off the main topic and never returns to the original goal of the communication. The conversational thread is permanently diverted. However, and this is the key distinction from more severe pathology, the listener can still understand the logical progression of how the patient got from point A to point B. The semantic link, though distant, is still intact.
But when that link breaks completely, we enter severe pathology.
Yes, that is known as derailment or loose associations. This represents a fundamental breakdown in the brain's associative networks.
Right.
The thoughts proceed from one idea to the next in a manner so convoluted, idiosyncratic, and random that the communicative value is entirely lost. The listener cannot follow the logic because the logic does not exist in any shared reality.
And if this profound derailment occurs in the context of hyper-accelerated, pressured speech, we term it a flight of ideas, which is a hallmark of severe mania.
And it devolves even further. You have clanging.
Right, clanging, where the brain stops connecting ideas by their meaning entirely and starts connecting them purely by the sound of the words, often through rhyming or punning.
I went to the store, the floor, the door, the bore.
Exactly. The semantic network has totally collapsed, leaving only acoustic associations. And finally, thought blocking, which is perhaps the most terrifying subjective experience.
The patient is speaking, and suddenly, mid-sentence, they stop.
The thought simply vanishes from their consciousness. The clinician is left sitting in this profound, heavy silence, watching a mind stall out. So that is the how. Now we must examine the what. Thought content.
Thought content encompasses obsessions, compulsions, overvalued ideas, and most critically, delusions.
And a delusion requires a rigorous definition to prevent us from simply labeling any belief we disagree with as pathological.
Right. A delusion is a firmly held false belief based on an incorrect inference about external reality. It is unshakable despite obvious, incontrovertible evidence to the contrary.
And there is a vital cultural caveat. It cannot be a belief ordinarily accepted by other members of the person's culture or subculture.
That cultural caveat is everything. If someone believes that burning sage clears negative energy, and they belong to a culture that shares that spiritual belief, that is not a delusion.
But if they believe that burning sage creates an invisible force field that deflects CIA mind control lasers, we have crossed into pathology.
Exactly.
The clinical framework divides delusions into two main spectrums. First, bizarre versus non-bizarre.
A bizarre delusion involves phenomena that are physically impossible within the patient's cultural reality. For example, believing that aliens beamed down and surgically removed your stomach overnight without leaving a scar.
And a non-bizarre delusion is unequivocally false, but it is physically possible, such as the belief that the FBI is tapping your mobile phone or that your spouse is having an affair. The second spectrum is mood congruent versus mood incongruent.
This helps us map the delusion to the underlying illness.
Right. If a patient is suffering from psychotic depression and believes they have committed an unforgivable mortal sin and deserve to die, that is mood congruent. The thought content matches the depressed emotional state.
But if a patient with schizophrenia has a completely flat, emotionless affect, yet believes they are the second coming of Christ, that is mood incongruent.
Let's run through some of the specific named delusions, because the psychology behind them is remarkable.
We have erotomanic delusions, where the patient believes with absolute certainty that another person, typically someone of higher social status or celebrity, is secretly in love with them.
We see somatic delusions, like the widow at the beginning of our deep dive who believed her organs were missing.
There are delusions of control, such as thought broadcasting, the terrifying belief that your internal thoughts are radiating outward and can be heard by everyone around you, and thought insertion, the belief that an external entity is planting alien thoughts into your mind.
And then there is the profoundly complex Capgras syndrome.
Capgras is haunting.
It really is. It is a delusion of misidentification where the patient believes that a highly familiar person, a spouse, a parent, a child, has been replaced by an identical-looking imposter.
And if we look at the neurobiology here, it perfectly illustrates the intersection of brain and mind.
Right. In a healthy brain, when you look at your mother, the fusiform face area in your visual cortex recognizes the physical geometry of her face. That signal is then sent to the amygdala, which generates a warm, familiar emotional response. You see her and you feel her.
But in Capgras, it is hypothesized that the neural wire connecting the visual recognition center to the emotional center is severed.
Exactly. It is a biological disconnection creating a psychological nightmare. The patient looks at their mother. The visual cortex says, "This looks exactly like my mother." But the amygdala is silent. There is zero emotional resonance.
The brain is presented with an intolerable cognitive dissonance. She looks like my mother, but she doesn't feel like my mother.
And the mind, desperately trying to make sense of this biological error, constructs a delusion to explain it. The only logical conclusion the compromised brain can reach is, this is an imposter. The delusion is actually an attempt at logic.
That brings up a fascinating philosophical point about delusions in general. They're not just random errors. They often serve a protective, explanatory function for a fracturing ego.
The literature provides a brilliant clinical vignette about a young college student developing schizophrenia. He is failing his classes, his cognitive abilities are visibly slipping, and his social life is evaporating. He suddenly develops a bizarre delusion that a vast conspiracy of his peers and professors is secretly sabotaging his work because his genius intellect is a threat to the academic establishment.
Why does his mind construct this specific paranoid fantasy?
Because the alternative is psychological annihilation. If he accepts the objective reality that a severe, chronic neurodevelopmental illness called schizophrenia is actively destroying his mind, eroding his future, and isolating him from humanity, his ego would entirely collapse under the weight of that grief.
The delusion, as terrifying and isolating as a conspiracy might be, places him at the center of the narrative. It makes him important. It makes him a genius. It protects him from the intolerable truth.
This is why directly attacking a delusion is clinically dangerous. You are attacking the psychological life raft keeping the patient afloat.
Which flows naturally into the realm of perception, where the brain misinterprets the physical world. This is where we assess for hallucinations.
An hallucination is defined as a sensory perception in the total absence of a corresponding external stimulus. You are hearing a voice when the room is silent.
The text notes that auditory hallucinations are by far the most common in functional, non-organic psychiatric conditions like schizophrenia.
Yes, and the literature provides a critical clinical heuristic regarding perceptual disturbances. The modality of the hallucination often points toward the etiology.
In North American and Western European clinical populations, visual hallucinations, olfactory hallucinations, smelling things that aren't there, or tactile hallucinations, feeling bugs crawling on your skin, should immediately trigger a high index of suspicion for an underlying organic medical cause.
You must rule out delirium, alcohol withdrawal, temporal lobe epilepsy, or an intracranial mass before you assume a primary psychiatric disorder.
However, we must again apply the cultural caveat. In certain global cultures, visual hallucinations are a frequently reported standard presentation of schizophrenia. Context is everything.
We also have to differentiate hallucinations from illusions. An illusion is a misinterpretation of an actual physical stimulus. You wake up in a dark room, you see a coat hanging on a chair, and for a split second, your brain processes it as an intruder standing in the corner. The stimulus is real, but the perception is distorted.
And beyond that, the literature defines several profound existential perceptual shifts that alter the philosophy of the self.
Derealization, where the external world suddenly seems two-dimensional, colorless, or entirely fake like a movie set.
Depersonalization, where the sense of self fractures and you feel as though you are floating outside your own body, observing yourself as a stranger.
And a fascinating one, jamais vu.
Jamais vu translates to never seen, and it is the exact neurological inverse of déjà vu. In jamais vu, a person is in a situation, a place, or with a person that they know objectively should be incredibly familiar to them, yet their subjective perception is that it is entirely foreign, strange, and novel.
It is a temporary glitch in the brain's familiarity recognition networks. The brain's ability to construct and destruct our reality is staggering.
Finally, the mental status examination concludes with insight and judgment, and the conceptual point here is critical. While both are higher-order executive functions housed in the frontal lobes, they do not necessarily align.
We tend to assume that if someone understands their situation, they will act accordingly. But neurobiology disagrees.
They are distinct cognitive domains that must be evaluated separately. Insight refers to the patient's capacity to appraise their own condition. Do they recognize that their thoughts are abnormal? Do they understand they are ill and require treatment?
Judgment, on the other hand, is the capacity to consider alternatives, predict consequences, and execute a safe, rational course of action.
You can have a patient with profound, pristine insight they can articulate. I know I have bipolar disorder. I know I am entering a manic phase. And I know my bank account is overdrawn, who still possesses catastrophically impaired judgment.
And immediately leaves the clinic to sign a lease for a luxury sports car they cannot afford. Awareness does not equal behavioral control.
This brings us to the integration and clinical reasoning phase. We have looked at the theoretical models, the unconscious dynamics, and the specific physical signs. Now, how does the clinician actually navigate the conversation in real time to extract this data without destroying the alliance?
The clinical guidance categorizes interview techniques into two broad modalities: facilitating interventions and expanding interventions.
Facilitating interventions are designed to keep the patient talking along their current trajectory. They are subtle nudges. Reinforcement is as simple as saying, I see, or please go on.
Reflection is a significantly more powerful empathic tool. The clinician simply repeats the patient's exact words back to them with a questioning or empathetic intonation.
If the patient sighs and says, "The voices are just getting so loud lately," the clinician softly replies, "Getting so loud."
It is not a demand for information, it is an acknowledgement that you are listening, which naturally prompts the patient to elaborate further without feeling interrogated.
And then there is the intervention that terrifies junior clinicians the most: silence.
Oh, silence is hard. We are socially conditioned to abhor silence. If there is a pause in a conversation, we rush to fill it. But in a psychiatric interview, silence is a scalpel.
As the literature notes, an experienced supervisor once told a frantic trainee, "Don't just do something, sit there."
Sometimes a patient has just touched upon a profound, painful truth, and they need time for the emotional resonance of that truth to settle. If you interrupt with a new question, you abort the psychological process.
Conversely, expanding interventions such as clarifying, leading, and probing are more directive. They're utilized when a topic is exhausted or when the clinician needs to shift the focus to uncover hidden pathology.
But this is where the cognitive biases of the interviewer become incredibly dangerous. We have to discuss the trap of normalizing. The human brain, including the doctor's brain, naturally seeks order. When we hear something bizarre, our brain tries to force it into a familiar, logical framework.
Which brings us back to our opening metaphor, the empty inside vignette. The resident heard the 62-year-old widow say she was empty inside and immediately normalized it.
They applied what psychoanalytic theory calls secondary process thinking, which is rational, metaphorical, adult logic to interpret the patient's primary process thinking, which is primitive, literal, concrete, and in this case, actively psychotic. The resident assumed a metaphor where none existed.
And the supervisor in that vignette demonstrated masterful clinical reasoning. They stepped in and utilized an expanding intervention clarification. They'd simply asked the patient to explain exactly what she meant by empty inside.
And that is when the terrifying somatic delusion that her internal organs had vanished was revealed. The resident missed it entirely because they wanted the patient's mind to make sense.
The literature provides another equally stark vignette to drive this point home: the unwind vignette.
Yes, imagine a 28-year-old man sitting in an interview. Right in the middle of a sentence, he suddenly stands up, turns a full 360 degrees in a circle, sits back down, and resumes talking as if nothing happened.
The natural, normalizing instinct of a tired clinician might be to ignore it or assume he's just stretching his legs. But if asked what just happened, the patient replies that he had to unwind.
Again, this is profound, concrete, primary process thinking. The patient felt psychologically tense, wound up, and his psychotic mind translated that metaphor into a literal, physical necessity to physically unwind his body.
By actively exploring that bizarre behavior rather than normalizing it away, the interviewer uncovered an entire hidden network of psychotic features. The rule is, never assume you understand the patient's metaphor. Always clarify.
So how does the literature suggest we manage the most challenging, high-friction scenarios? Let's take the severely depressed patient. They possess profound psychomotor slowing. It takes them 10 seconds to answer a question.
They radiate hopelessness, repeatedly saying, "What's the use? Nothing will help." The clinical gravity in the room is suffocating.
In that scenario, the clinician must lean entirely on the therapeutic alliance. You cannot argue a patient out of depression. You cannot present logical evidence that life is worth living.
You must tolerate their despair without being consumed by it, offering a persistent, quiet, hopeful presence. You reflect their pain, validate their exhaustion, and gently guide them through the necessary data gathering, often relying on closed-ended questions to reduce their cognitive burden.
For the actively delusional patient, as we discussed with the paranoid student, the golden rule is a delicate tightrope. You must neither endorse the false belief nor directly challenge it.
Because if you agree that the CIA is listening, you join the psychosis. If you tell them they are crazy, you become the enemy and the interview is over.
Precisely. The technique is to sidestep the cognitive content of the delusion and aim directly at the underlying emotion. You say, "I do not hear the voices you are describing, and I know we see this differently, but I can see that the experience is absolutely terrifying for you, and I want to understand how that fear is affecting your life."
You anchor the alliance in shared emotional reality, even while your cognitive realities diverge.
What about a scenario where the patient is actively, intentionally deceiving the clinician, malingering? How do you approach the mind when the mind is lying to you?
You have to approach it by understanding the motivation, the why. Deception in a clinical setting is typically driven by one of two mechanisms. The first is secondary gain. These are tangible, external, real-world rewards.
The patient might be feigning psychosis to avoid a prison sentence, exaggerating depression to secure financial disability payments, or fabricating pain to acquire controlled substances.
The second mechanism is primary gain. This is entirely internal and psychological. The patient adopts the sick role because being a patient fulfills a desperate, unconscious psychological need for care, attention, and nurturing that they cannot achieve in the real world.
The clinician must remain vigilant, look for inconsistencies in the clinical presentation that do not match known biological patterns, but also maintain humility. The literature admits that even the most seasoned clinicians can be, and frequently are, deceived.
And wrapping around all of these scenarios is the vital context of cultural variations. We touched on this with hallucinations. Culture is the lens through which distress is interpreted and expressed.
If a clinician is ignorant of the cultural idioms of distress of the person sitting across from them, the risk of diagnostic catastrophe is immense. You can easily misread a deeply held cultural or religious belief as a bizarre delusion, leading to horrific overmedication and stigmatization.
Which brings us finally to the culmination of the entire labyrinthine process, the formulation.
The psychiatric formulation is the synthesis of everything we have discussed. It is where the psychiatrist pulls together the reductionist objective data, the genetics, the PSYCH criteria, the lab results, and marries it to the holistic, subjective narrative of the patient's life, their traumas, their culture, and their defense mechanisms.
It bridges biology and philosophy and answers the question, why is this specific person experiencing this specific illness at this specific time?
And as you move to close that interview, having gathered all this profound material, the clinical guidance offers one last crucial piece of structural advice: the 10-minute warning. You must explicitly tell the patient we have to end our session in about 10 minutes.
Why? Because of the phenomenon known as the doorknob disclosure. Patients driven by unconscious anxiety are notorious for withholding the most critical, devastating piece of information. By the way, I bought a gun yesterday until the very last second, right as their hand is on the doorknob leaving the room.
The warning gives their unconscious mind the time to process the ending and brings that vital information into the safety of the session while you still have time to manage it.
It is the final boundary that creates safety.
We have covered an immense landscape today. To reinforce the core concepts, the mechanisms, and the clinical reasoning we've explored, we are going to run through several single best answer or SBA-style questions drawn straight from the literature's core teachings.
I'm going to read the question. I want you, the listener, to pause the audio, refer back to the mental models we just built, and lock in your answer before our expert provides the solution. Question 1. In the context of the mental status examination, which of the following statements best describes the clinical and conceptual difference between mood and affect?
The defining difference revolves around subjective experience versus objective observation. Mood is the internal, sustained emotional climate, as described subjectively by the patient, for example, a patient stating, "I have felt hollow for weeks." Affect is the outward, objective, momentary manifestation of that state as observed by the clinician in the room, such as observing tearfulness, a blunted facial expression, or psychomotor agitation.
Question 2. During an interview, a patient answers a question by veering off into a related, somewhat logical topic, but they never actually return to answer the original question. The listener can follow how the ideas link together, but the destination is lost. What specific thought process abnormality does this represent?
This represents tangential thought. The critical clinical differentiator here is that in circumstantial thought, the patient takes a highly circuitous route with excessive detail, but they do eventually return to answer the target question. In tangential thought, they take an exit ramp and never return to the original goal, though the semantic associative links remain somewhat intact, unlike the total collapse seen in derailment or loose associations.
Question 3. A psychiatric resident is interviewing a grieving 62-year-old widow who states she feels empty inside. The resident assumes she's expressing the emotional loneliness of grief and makes a psychological interpretation, failing to realize the patient has a somatic delusion that her organs are missing. What specific error in clinical reasoning and interviewing technique has the resident committed?
The resident has committed the error of normalizing. Conceptually, they used secondary process thinking, which is rational, metaphorical, and adult-oriented, to interpret what was actually primary process thinking, which is literal, concrete, and psychotic. They failed to utilize an expanding intervention, specifically clarification, to understand the patient's unique meaning, instead projecting their own logical framework onto the patient's pathology.
Question 4. According to the clinical and philosophical frameworks of the psychiatric interview, what is the defining characteristic that separates empathy from sympathy, and why is this distinction critical for the therapeutic alliance?
The defining characteristic is the maintenance of clinical objectivity. Empathy involves the capacity to deeply understand and emotionally resonate with the patient's subjective experience while firmly maintaining the boundary of the self. Sympathy involves identifying with and fusing with the patient's pain. This loss of objectivity distorts the relational dynamic, often leading to enmeshment, and stunts the clinician's ability to provide effective, grounded psychiatric care.
Question 5. During the risk assessment portion of an interview, a severely depressed patient admits to having suicidal ideation and states they own a firearm. According to the chronologic assessment of suicidal events or case approach, what is the most appropriate immediate next step for the clinician?
The clinician must move systematically down the continuum of lethal planning by asking concrete, behavioral questions rather than abstract ones. According to the case approach, if the patient admits to having a weapon, the immediate next questions must determine proximity to action. Have you taken out the gun? Did you purchase ammunition? And did you load it? The goal is to bypass psychological denial and establish exactly how close the patient came to a lethal act.
Unbelievable depth today. We have traveled from the shifting emotional walls of the clinical labyrinth through the precise neurobiological mechanisms of delusions and pot disorders, and arrived at the philosophical synthesis of the psychiatric formulation.
But I want to leave you with one final provocative thought to mull over a paradox at the very heart of this field. We established at the beginning that in psychiatry, unlike the rest of medicine, the conversation is the instrument. The mind of the psychiatrist is the primary tool being used to measure, evaluate, and heal the mind of the patient. But if the human mind is both the complex subject being examined and the only instrument we have available to examine it with, what inherent, unfixable blind spots will we always possess in our pursuit of understanding human distress? Here are the details of this episode.
Approaches from Philosophy and Psychology. Byline. Before we treat the mind, we must ask what a mind is. Episode description. This chapter explores the philosophical and psychological foundations that underpin our understanding of personality and psychopathology. It moves beyond empirical observation into the deeper questions that shape how we conceptualize human experience. Philosophical traditions have long grappled with the nature of self, consciousness, free will, and meaning. These questions are not abstract. They directly influence how mental illness is defined, understood, and treated. Whether one views the mind as a biological machine, a subjective experience, or a relational process fundamentally alters the clinical approach. Psychological frameworks build upon these philosophical roots. Trait theories, humanistic psychology, and cognitive models each offer different ways of understanding personality. Some emphasize stability and structure, others growth and self-actualization, and others the role of thought patterns in shaping experience. A central theme is plurality. There is no single unified theory of personality or psychopathology. Instead, multiple frameworks coexist, each capturing different dimensions of human experience. The challenge is not to choose one, but to understand their assumptions and limitations. The chapter also highlights the tension between reductionism and holism. Can the mind be fully explained by biology, or does it require a broader understanding that includes meaning, context, and subjective experience? Clinically, these perspectives shape how we listen to patients, interpret symptoms, and choose interventions. They influence whether we see distress as dysfunction, adaptation, existential struggle, or something else entirely. Ultimately, this chapter reminds us that psychiatry is not only a medical discipline, it is also a philosophical one. Key takeaways. Philosophical assumptions shape how the mind and mental illness are understood. Key concepts include self, consciousness, free will, and meaning. Psychological theories offer diverse models of personality. No single framework fully explains psychopathology. Reductionist and holistic approaches offer different insights. Clinical practice is influenced by underlying theoretical assumptions. Psychiatry sits at the intersection of science, psychology, and philosophy.